Hello, my name is Christopher Stockdale. I'm a fourth year medical student at Loyola University Chicago. I'm currently taking the emergency medicine ultrasound elective, and today I'm going to be talking about renal masses with ultrasound. So a little bit about what we're going to talk about today. Something I'm not going to talk about much is how to perform a renal ultrasound. There's already podcasts about that on the website. It's a little bit outside the scope of what I want to talk about, and it would be a little bit repetitive. So instead, I'm going to talk about masses that can be determined with ultrasound. And one of the reasons I want to talk about this is because ultrasound is often the first imaging modality which is used to view kidneys. Many renal masses are found incidentally, either with ultrasound or CT, and so this is one of the cases when doing an ultrasound you might find a renal mass incidentally, and at which point it would be important to differentiate between what the masses are in terms of prognosis for the patient, or how important it actually is for the patient to even worry about. So the other thing with that in mind, and since this is an ultrasound lecture, I'm going to focus on masses which can be detected by ultrasound and then can be differentiated as well. There's a lot of renal masses I'm not going to talk about today. And then the last thing I'm going to talk about is studies which use contrast enhanced ultrasound to look at renal masses and differentiate between some important different masses. So it's a little outline of where we're going to be going. First, just to take a look at the anatomy of a normal kidney. Two different representations of a normal kidney here, both somewhat cartoony. On the left, you have more of the collecting system outlined with the calyces, the infundibulum, and then the pelvis. And on the right, have a little bit more of the parenchyma defined here with the papillae, the pyramids, and the columns, the cortex, and then the capsule. So just a brief reminder of what the kidney should look like normally. And since this is on ultrasound, let's take a look at what an ultrasound would look like. There's two typical views to look at the kidney with ultrasound. The first is longitudinal, the second is transverse. So up on the top up here, we have the longitudinal view. You can see the renal parenchyma here represented on the long axis. You can see the different parts of the kidney if you look at it closely. And then down here we have a transverse view, which this is the kidney here, and then you can see the collecting system. So those are the two typical views that you would see when looking at a kidney. So just a reminder of what a normal kidney would look like under ultrasound. These are the masses we're going to talk about today. These some of the most common types of masses. These are the ones I'm going to focus on, like I said, because of how ultrasound can be used with them. With masses of any type, but especially renal masses, they can be put into two different categories, either benign or malignant. When looking at benign renal masses, the most common are cysts, but then there's also AMLs, which we'll talk about. And then one we're not really going to talk about today is oncocytomas, mostly because they're visible with ultrasound, but you pretty much always have to do a CT or MRI to follow up on it because they're difficult to differentiate from renal cell carcinoma with ultrasound. And I didn't find a lot of studies that show a good way to differentiate between the two. So I'm not going to talk about oncocytomas, even though they are visible. And then the malignant masses we're going to talk about are two of the more important ones. First of all is primary tumor renal cell carcinoma. And then the second one I'm going to talk about is renal metastasis and what metastasis to the kidneys would look like. I'm not going to talk about some of the other tumors, such as Wilms tumor, just because of the scope of this presentation. So first, looking at benign masses, one of the most common is a renal cyst. So simple cysts are benign. A simple cyst is defined as being fluid-filled, thin walls, no septae. So these have a very, very low malignant potential, if you remember. And they're relatively common. It's one of the most common incidental findings on a kidney, either with an ultrasound or a CT or any imaging. It's important to note that more complex cysts, there's an entire grading system outside the scope of this presentation, that more complex cysts may have malignant potential. So here's an ultrasound image to give an idea of what a cyst would look like on a kidney. Here you have the renal parenchyma over here, and then you see a cyst, which is looks like it's coming out of the kidney, which essentially it is. And so this here is outlining across the cyst. This is the cyst. Cysts, as I said, simple ones as this one is, are fluid filled. So as a result, they are hypoechoic on ultrasound. And another thing to note is down here, it's a little brighter, a little enhanced, and that's acoustic enhancement posteriorly, which is something you'll see with simple cysts or cysts on ultrasound, much like you'd see on the bladder or any other fluid-filled mass or fluid-filled area with ultrasound. So that's how you can differentiate simple cysts, which, like I said, if they're simple, they have a very minimal, very minimal malignant potential, virtually none. So something to keep in mind with benign masses. Another one of the more common benign masses is AMLs, which are blood vessels, smooth muscles, and fat all together. These are the tissues within the mass. So angiomyolipoma, just literally naming the three different tissues within the mass. These are relatively common. They can be associated with tuberous sclerosis, at which point there'd be multiple and they'd be bilateral. But most common, they're sporadic. They tend to occur unilaterally with a single AML in women aged 40 to 60. Here's a good example on ultrasound of what you would find. AMLs, here's again the renal parenchyma, and then you can see the AML right here. And AMLs are hypoechogenic on conventional ultrasound. So you can tell because they're hypoechogenic that is an AML and is not a renal cell carcinoma for the most part. We'll go into a little more detail later about how to differentiate between renal cell carcinoma and AMLs. So now on to malignant masses. So perhaps the most important renal mass that you can see on ultrasound is renal cell carcinoma, or RCC. Now, just a brief reminder, renal cell carcinomas present with the classic clinical triad of hematuria, abdominal pain, and a palpable abdominal mass. This is actually very uncommon for a patient to present with the clinical triad, however. Most renal cell carcinomas are actually found incidentally. The patients are asymptomatic. With the imaging we have today, these tend not to be found with the clinical triad. It may have hematuria or one of the different symptoms, but generally not the full-blown clinical triad. It's just not the case now. But that is important to know that is the traditional appearance. On ultrasound findings, what you'll see here is there's the renal parenchyma, and you can see a mass attached to the renal parenchyma, and this is suitably noted by an M. This is the renal cell carcinoma, and what you see is a hypoechoic mass. Generally, it's smaller. The smaller ones can be. This is where it gets confusing, because even though they're hypoechoic, the smaller ones can be hyperechoic, and therefore, if you remember, AMLs are hyperechoic. It can be difficult to differentiate, and AMLs are benign, and renal cell carcinoma obviously is not benign. However, these do tend to be hypoechoic, as this mass is. So that's your classic presentation on ultrasound of a renal cell carcinoma, and I'll go into a little bit more detail on that in a minute. The last mass I want to talk about is metastasis to the kidneys. So as you would expect with metastasis to the kidneys, since it's secondary, it's not a primary tumor, it won't be a single mass. Primary tumors like renal cell carcinoma tend to be a primary single mass, but with metastasis you have multiple masses. So here's a good ultrasound view of it. Now these can be either hypoechoic or hyperechoic masses, making them a little confusing, but here's a good one. This is the liver up here, denoted by the L. Here you have the renal parenchyma, and then within it you see these arrows which are pointing to the different metastases, the masses within the kidney, and in this case they're hypoechoic. So that's an example of ultrasound findings for a patient with metastasis to the kidney. Just a quick overview. Most commonly, you'd obviously want to do a full scan afterwards if you see metastasis, because most commonly these mets are from the lung, the breast, GI system, or melanoma. So one of the last things I want to talk about is take a look at this study, which looks at one of the issues I've brought up during the course of this presentation, which is differentiating between small renal cell carcinoma and AMLs. So this is a concern because small renal cell carcinoma can be hypoechoic, or can be hyperechoic, whereas AMLs are generally hyperechoic. So they're very difficult to differentiate. One is completely benign, and one has malignant, and obviously you'd want to treat the patient accordingly. So this study I'm going to talk about is from the Korean Journal of Urology, published in 2014, and what they used is contrast-enhanced ultrasound for renal masses. So looking at contrast-enhanced ultrasound, why is it important? Well, as you can see, like I said, it's difficult to differentiate between small AML or small RCCs and AMLs. And roughly 30 to 40% of renal cell carcinomas at small sizes are actually hyperechoic, which makes them appear like AML. And by small sizes, we're talking, this study looked between 1.2 and 4 centimeters is the masses they looked at. And as a result, when patients have a small finding on ultrasound, they tend to have contrast CT or MRI ordered to differentiate between AML and renal cell carcinoma. And one of the concerns brought up in the study is that contrast is nephrotoxic, and also CT and MRIs are very expensive for what could be a benign mass for this patient in AML. So they were looking at using contrast-enhanced ultrasound to differentiate. Contrast-enhanced ultrasound is where the patient will take contrast, much the same as in other imaging modalities. However, the contrast used in ultrasound is less nephrotoxic, it has less side effects, and obviously ultrasound is much cheaper than CT or MRI and also less invasive for the patient. So in this study, there were 49 total patients. They had 38 with renal cell carcinoma and 11 with AML. They first, with both sets of patients, used conventional ultrasound to see the findings, and what they found was in line with what the literature says, that 60% of these patients with these small renal masses that had renal cell carcinoma had hypoechogenic findings. So what you would expect to see as the more typical presentation on ultrasound of a renal cell carcinoma. However, 40%, which is a very large number obviously, had hyperechogenic, at which point would look a lot like AMLs. So a very large percentage, not enough to tell someone, oh, it's hyperechogenic, you don't need any further testing. Obviously, there's still a good chance it's renal cell carcinoma. In terms of the AML patients, large majority had hypoechogenic lesion or masses, and 27%, however, had hypoechogenic. So there's a lot of overlap here, you can see. So then they added the contrast-enhanced ultrasound to see how that would improve the situation. And what they found is that with the 38 renal cell carcinoma patients, 100% of them showed hyperenhancement. And I'll show some images of what that looks like. And 0 of them had hypoenhancement. So that's clearly a way to differentiate that, okay, if it has hyperenhancement, if it does not have hyperenhancement, if it has hypoenhancement, then it's most likely it's going to be an AML. And you don't need to do follow-up studies. AMLs were a little less clear. 64% had hypoenhancement, but 36% still had hyperenhancement. So it's not perfect by any means, but it does provide a little bit more opportunity to do more accurate testing with these patients. So here's a look at the images. So first we'll look at the renal cell carcinoma images. This is the conventional ultrasound up here. You can see the arrow pointing to the mass. This is a more typical presentation. So this patient has a hypoechoic mass, which is what you would expect to be a more typical presentation for renal cell carcinoma. And then the most important thing we see on this contrast-enhanced ultrasound is the arrow pointing here to the mass which has hyperenhancement. So you can see it's enhanced quite a bit compared to the surrounding tissue. And so that's a sign that 100%, like I said, of the renal cell carcinoma patients did have hyperenhancement. If we look at AMLs, here's the image on conventional ultrasound. You can see that it's hyperechogenic right here, which is typical for a conventional ultrasound of an AML. But then on the contrast-enhanced ultrasound, you can see what they call pinpoint contrast enhancement or pinpoint hyperenhancement. And why is it pinpoint? Because remember, AMLs do have the angio portion, so there will be vasculature through there. However, the uptake isn't the same as in the renal cell carcinoma, so you don't see the diffuse enhancement that you see on the renal cell carcinoma. So that's how you can differentiate with contrast-enhanced ultrasound. So their conclusions were that contrast-enhanced ultrasound does allow for the differentiation on many of these tumors between renal cell carcinoma and AML. Remember, renal cell carcinoma needs to be treated. AML is benign, and in most cases, unless there's hemorrhage or a mass effect, does not need to be treated surgically. So their conclusions were that using contrast-enhanced ultrasound may decrease the necessity of additional diagnostic imaging for patients with small renal masses. So certainly there seems to be a place for contrast-enhanced ultrasound, and it can be useful for these small renal masses. So the take-home points from this presentation are that in terms of benign masses first, renal cysts are hypoechoic, they are fluid-filled, therefore they also have acoustic enhancement posteriorly, they're benign, no treatment is generally needed unless they're larger or complex. In terms of AMLs, AMLs are hyperechoic on conventional ultrasound, although some portion are hypoechoic, and they usually show hypoenhancement or pinpoint enhancement on contrast-enhanced ultrasound. Renal cell carcinomas are tend to be conventionally hypoechoic on conventional ultrasound, and they can show, or rather do always show, hyperenhancement on contrast-enhanced ultrasound. And one of the important things to remember is that small renal cell carcinomas, 4 centimeters or less especially, tend to present very similarly on ultrasound to AMLs. 40%, 30 to 40% will be hyperechoic, much like AMLs, rather than hypoechoic. In which case, as the study showed previously, contrast-enhanced ultrasound can be used to differentiate between these small RCCs and AMLs. And this concludes my presentation on renal masses with ultrasound.